And all. So today let us discuss the topic about surgical disease of parathyroid gland. So coming to anatomy, so there are four parathyroid glands, includes two superior and two inferior. So it is flat, ovoid and reddish brown to yellow. So it measures about 3 into 3 into 3 millimeter. So it weighs about 30 to 50 milligram. So the main blood supply for this is the inferior thyroid artery. So develops at 4th to 5th weeks of fetal life. That is pharyngeal pouch will develop. So it develops fourth pouch and lateral thyroid antlers develops at superior gland, and third pouch and thymus develops at inferior gland. So coming to primary function is the endocrine regulation of calcium and phosphate metabolism. So hormone regulation of calcium and phosphate metabolites. So in this parathyroid hormone, vitamin D and calcium are included. So in this under gastrointestinal tract and skeleton and kidneys. So GIT of PTH there is no direct effect. And coming to vitamin D, it stimulates calcium and phosphate absorption, and calcineurin there is no direct effect. Coming to skeleton, it stimulates calcium and phosphate resorption, and vitamin D it stimulates calcium and phosphate transport. And in calcineurin, it inhibits calcium and phosphate resorption. And in kidneys of PTH, that stimulates calcium resorption, inhibits phosphate resorption. Vitamin D, there is no direct effect. And in calcineurin inhibits calcium and phosphate resorption. So in the cycle, there is a feedback loops involved in the regulation of serum calcium and phosphorus. So coming to primary hyperparathyroidism. So inappropriately increased amounts of parathyroid hormone related to serum calcium level. So it occurs in 1 is 1,000 population. The increased detection due to increased use of serum determination. So there are three histologic patterns involved: single adenoma, hyperplasia, and parathyroid carcinoma. So next three histology patterns. Single adenoma. So 90% of cases involve the remove normal parathyroid tissue around the adenoma, distinguish adenoma from hyperplasia. So in hyperplasia, there's 10% of cases involved. So there's no rim of normal parathyroid tissue and lack of stromal fats, and all four glands are involved. So hyperparathyroidism of men's syndromes is due to hyperplasia. And in parathyroid carcinoma involves less than 1% of cases. Exceptionally, high calcium or palpable neck mass should raise suspicion. Excision with thyroid lobectomy is indicated, or radical neck dissection for recurrent disease. So recur locally 30%. So distance matters includes lung, liver, bone, and 30%. And coming to clinical presentation, so 70% of patients are asymptomatic, present with stones like nephrogenic conditions like nephrolithiasis or nephrocalcinosis, or 10 to 20% of patients usually calcium phosphate. So calcium oxalate is less common. And then bone, there's a patient complains with bone pain, arthralgia, muscular aches. Coming to 20% of symptomatic patients, cortical resorption with medullary bone sparing secondary to increased turnover. So osteoitis fibrocystica is the condition where resorption leads to brown cysts in the bone predisposed to fractures. And then Crohn's, peptic ulcer disease and pancreatitis. 20% of symptomatic patients will come. And then psychic patterns, patients will develop fatigue, depression, anxiety, irritability, lack of concentration, sleep disturbance. And 40% of symptomatic patients, there is no relationship of parathormone or calcium levels to severity of symptoms. Surgery improves all symptoms except anxiety. So physical examination is usually not helpful in diagnosis. If a mass is palpable, suspect thyroid pathology or parathyroid carcinoma. So coming to laboratory examination, so hypercalcemia, hyperphosphatemia, hypercalciuria are the classic hallmarks of hyperparathyroidism. So parathermal levels are elevated related to serum ionized calcium level. So whether it can be abnormal or upper normal. So serum phosphorus will be low in primary hyperparathyroidism, high in secondary hyperparathyroidism. So chloride will be high secondary to renal HCO3 in wasting, the direct effect of PTH. Chloride to phosphorus ratio of more than 33 is diagnostic of primary hyperparathyroidism. So poor man's parathyroid hormone assay. So malignancy with or without bone metastasis is cause of more than 50% of hypercalcemia. So includes hematologic, lung, pancreas, bone, ovary, breast, and prostate. So coming to other causes of hypercalcemia, it includes endocrine disorders like hyperthyroidism, adrenal insufficiency, and pheochromocytoma, and vitamin D toxicity, and lymphoma with ectopic vitamin D production, granuloma disease like sarcoidosis, tuberculosis, histoplasmosis, coccidioidomycosis, leprosy, and drugs involves like thiazides, lithium, milk alkali syndrome, immobilization. And coming to radiology examination, so subperiosteal resorption is the classic distribution of radial aspect of second and third phalangeal tufts and distal clavicle. And then it shows solitary bones is called brown tumors. So intravenous pyelogram may show urolithiasis or nephrocalcinosis. And coming to medical treatment, So symptoms include anorexia, nausea, vomiting, polyuria, polydipsia, abdominal pain, lethargy, bone pain, and muscle weakness. So if it is untreated, may progress to dehydration, oliguria, acute tubular necrosis, and delirium with NOS. Rapid rehydration with normal saline to restore urine output. So forced diuresis with furosemide drip. So it should be started 10 to 20 mg per hour. So steroids can be given like etidronate disodium 7.5 milligram per kg IV daily for 3 days, followed by 5 to 20 mg per kg per oral daily. Inhibits bone metabolism in hypercalcemia of malignancy. This should not be used in renal failure patients. Mithramycin may be used as last resort. If not used properly, can lead to aplastic anemia. Should be started 25 microgram per kg for 4 hours. And dialysis can be used to lower serum calcium emergently. And then management primary hyperparathyroidism. So surgery is treatment for the hypercalcemia of hyperthyroidism, so but only after hydration with adequate urine output is established. So surgical indication like parathyroid carcinoma, asymptomatic patients with presence with persistent calcium elevation 1 to 1.6 mg per dl above normal, and calciuria should be more than 400 mg per day. So decreased bone density more than 2 uh, standard deviation points from normal age, sex, and race. So creatinine clearance should be decreased by 30% below normal for age and sex and race. So symptomatic patients include urolithiasis or nephrocalcinosis, peptic ulcer disease, pancreatitis, and musculoskeletal symptoms. So coming to localization techniques, includes ultrasound can be detected 80% accuracy for glands as small as 3 millimeter, will not detect mediastinal tumor. CT scan or MRI will detect mediastinal tumors more than 2 centimeter. Thallium, in this technetium subtraction scan can be used for 80% accuracy, arteriography 50% accuracy, selective venous sampling for parathermal 70% accuracy. Coming to post-op care, there is airway management must be needed. Hypocalcemia is common and occurs almost immediately. Monitor serum calcium levels. Symptoms include anxiety, hyperventilation, chest and trousseau signs, acral and circumboreal paresis. Some advocate treating only symptomatic hypocalcemia. So treat hypocalcemia with oral calcium carbonate 1 gram per hour. So 6 hourly, or IV calcium gluconate for severe hypocalcemia less than 7. So vitamin D supplementation may be necessary for refractory hypercalcemia. Watch out for any bleeding or infection. So coming to secondary hyperparathyroidism. Hyperparathyroidism secondary to malfunction of another organ system. So usually occurs in patients with chronic renal failure, but may also due to osteogenesis imperfecta, Pacey disease, or multiple myeloma. So coming to pathophysiology in renal failure, so there is increased phosphate because of poor renal excretion and decreased serum calcium, decreased gut absorption of calcium due to decreased renal 1 hydroxylation of vitamin D2, and decreased renal clearance of parathermal breakdown products. And the secondary hyperparathyroidism clinically manifests as psychiatric disorders, headache, muscle weakness, weight loss, fatigue, renal osteodystrophy, and soft tissue calcifications. The treatment is directed at underlying disorder. Phosphate binding antacids, oral calcium and vitamin D, increased calcium dialysate for chronic renal insufficiency patients. So surgery is indicated for uncontrolled symptoms like either 3.5 gland parathyroidectomy or 4-gland parathyroidectomy, and with implantation of meningeal glands into sternocleidomastoid or forum muscles marked by surgical clip. So coming to tertiary hyperparathyroidism. So there's persistent hyperparathyroidism and hypercalcemia following successful renal transplant or resolution for underlying disorder. So up to 30% of patients who have pre-transplant hyperparathyroidism pathophysiology is irreversible. Parathyroid gland is hyperplasia with autonomous parathermal production. And then surgery is indicated for symptomatic patients, but patients with unresponse to medical management 6 months post-transplant, like either 3.5 gland parathyroidectomy with implantation of meningeal glands into muscle. Thank you.